An electrocardiograph must be studied systematically, step by step, so that even minor changes are not missed. Here I have presented one way or order of reading the electrocardiograph. With practice, you may develop your own order of observation, but the important thing is not to miss out on any point. When you read an ECG, first inspect lead AVR. In this lead, all waves should be inverted. If they are upright, then probably limb leads were wrongly connected and ECG interpretation should be avoided. Only exceptionally it may be upright due to dextrocardia. Then calculate the heart rate. Then study the P wave morphology in lead 2 where it is most prominent. If it is more than 2 mm wide or 2 mm tall, then left or right atrial hypertrophy may be present, and an inverted P wave in lead 2 indicates nodal rhythm. Then measure the PR interval. Normally it is 3 to 5 mm. If it is increased to 5 mm or more, it is a first degree AV block. In such a case, note if there are any dropped beats suggesting second degree heart block. If the PR interval is reduced to less than 3 small squares or 0.12 seconds, look for slurring of R waves in leads 1 and V6 to rule out WPW syndrome. Now come to QRS complex. Look at leads 1 and 3 for axis deviation. Remember, left leaves and right reaches. Here both leads have upright QRS complexes, which is normal. Then measure the QRS interval in the lead in which it is most wide and clear. Generally, QRS is 2 to 2.5 mm wide. If it is more than 3 mm, that is 0.12 seconds, study whether it is left bundle branch block or right bundle branch block. Then look for pathological Q waves in anterior, inferior or chest leads. A Q wave deeper than 1 mm or wider than 1 mm or more than 1/3 of the R wave is considered as significant. Now come to chest leads and study the pattern of QRS complexes from V1 to V6. If the pattern is normal from deep S wave in V1 to tall R wave in V6, then measure SV1 and RV6 to rule out left ventricular hypertrophy. Here SV1 plus RV6 measures only 18 mm, which is less than 35 mm. If the pattern is changed, that is, if R wave is prominent in V1, then look for criteria of right ventricular hypertrophy or right bundle branch block. Next, we come to the ST segment. If the ST segment is elevated or depressed, the pattern must be studied and clinically correlated to myocardial infarction, myocardial ischemia, pericarditis, and ventricular strain patterns. Lastly, we study the T wave morphology and note the leads where it is tall, flat, or inverted. The details of STT changes are studied in the next section of this cassette. After studying the PQRST pattern, we shall study the rhythm strip, calculate the rate, and inspect grossly for arrhythmias. First, see whether normal P waves are present. Study the P wave and PR interval, whether the PR interval is increased, whether it is constant in all the beats, and whether every P wave is followed by QRS complex. Are the QRS complexes of normal configuration or bizarre? And are they related to the P waves or have their own different rhythm? If there are pauses, decide whether it is a premature beat with compensatory pause or sinus pause with escape beat or non-conducted atrial premature beat or second degree heart block. For every arrhythmia, you must locate the origin of the impulse and then conduction defects if any.